Welcome to the EAU podcast.
Welcome. I'm Carmen Mir. I'm the chief editor for the UROONCO Kidney Cancer platform from the European Association of Urology. Today, I'm delighted to be joined by Dr. Pedro Barata. He is an associate professor at University Hospitals, Case Western in Cleveland, Ohio. He is a medical oncologist by training, and he's one of the leading experts in kidney cancer and translational research. At ASCO 2026 this year, we saw a presentation about ctDNA analysis from the KEYNOTE-564 trial, evaluating whether circulating tumor DNA could actually help identify which patients with high-risk renal cell carcinoma could benefit from adjuvant pembro after nephrectomy. Pedro, thank you for joining us today and help us understand the implications of these findings into our practice as urologists. Before we get into any more details, can you briefly summarize the main findings of this ctDNA analysis from KEYNOTE-564 and explain why is this important?
Sure. No, thank you, Carmen, for having me. It's super important conversation. And just for context, so we are offering radical or partial nephrectomy, meaning local surgery interventions for patients diagnosed with RCC. And we know that a number of these patients will recur afterwards, right? And the question is, who are they? When we think specifically of what we call high-risk disease, which is not exactly the same as what we consider patients for adjuvant intervention, when we're now using the KEYNOTE-564, the same pivotal trial that led to pembro approval in this space, adjuvant space. And we include actually intermediate high risk and post M1 NED. In other words, we're talking about T2 plus tumors, nuclear grade 4 sarcomatoid features, and then beyond that. So thinking of that population, when you look at the patients who end up going on observation or surveillance, almost half of them end up not recurring. In other words, they don't need additional intervention. So with that in mind, we see a benefit in terms of delaying time in the scans as well as overall survival on the overall population when treated with adjuvant pembrolizumab for a year. And we see a benefit of disease-free survival, meaning delayed time in cancer in scans, when you add belzutifan to pembrolizumab on top of, compared to pembrolizumab alone. And that's based on the LIGHTSPARK 22 adjuvant study that was just read out a few months ago, ASCO. So if I were to summarize, I would say 2 or 3 things. One, patients at a high risk of recurrence, adjuvant immunotherapy-based strategies help to delay progression or delay recurrence. But at the same time, many patients, maybe 40+% of patients, may not need any additional intervention. So with that in mind, the question is, can we just focus on the patients who are going to require treatment because they were destined to recur? So that's kind of the mindset behind biomarker approaches in the adjuvant setting to try to see, okay, can we identify those patients and leave those patients that are cured alone without the possible toxicities from interventions they may not need? So ctDNA has been around in many tumors, including GU tumors. Actually, the better data or the best data out there in the GU world comes from bladder cancer, right? As you know, Carmen, we now have evidence, very good evidence, that if you do assess minimal residual disease with a tumor-informed test, you're basically able to identify those who are destined to do better versus those who are destined to do worse. And on top of that, you are able to identify who tends to benefit the most from immunotherapy. That's bladder cancer world. So the question is, can we apply this to kidney? So on this KEYNOTE-564, the similar test called Signatera available out there was done at baseline and then different time point while they go on immunotherapy. And as you can imagine, important questions can be asked, right? Like when you find, how many do you find MRD there? And what happens when you give them pembro? And what happens to the outcomes of those patients? So all of those are important conversations. And as a way to summarize that, I would say, it's not surprising, RCC is known as a low tumor shred tumor. In other words, you don't find positive ctDNA often, less than 10%. So you test 10 times, you're going to find 1 out of those 10. Remember, we're just talking about the KEYNOTE-564 population. Again, intermediate high risk of post M1 NED. So I'm not even talking about those small renal masses. But when you look at the results presented, you see that patients who receive pembro, whether or not they had positive ctDNA, the benefit driven by the other ratio of the pembrolizumab seems to be there. So the ability of the ctDNA to predict the benefit of immunotherapy is not there. So we lacked, or at least the study suggested, a lack of predictive value. Now, on the other hand, patients who are positive, meaning you're detecting MRD post-surgery, are destined to do worse than those who aren't. And that gives you a sense of the prognostic value of those tests. That's maybe a way to look at the data. There's another nuance to this, which is what happens to those patients who are first positive and then become negative, and they do better than those who never go negative. And this is kind of aligned with what we would think common sense, and also aligned with what we've seen in other tumors. You want not to detect MRD. That's a good thing, but there are limitations inherent to RCC that I think future next level tests may need to address to become available and ready for prime time.
There was some sub-analysis also in this presentation that was about looking a little bit more amount of genes in the ctDNA instead of looking at the 16 plex that we have been looking at over the few trials that we had, like in Vigor, looking at more genes. But what did they find with that? Do you think it was any different?
Yeah, it's a great question. So just for context for our audience, so when we do MRD tests, minimal residual disease tests, we can do it in two ways. One, we can find the tumor-specific signature. What does that mean? You send the tissue, you find out what that means, and they're going to go after that signature in the blood. So you need tissue and you need blood the first time around. After you identify, let's call it a signature, which you mentioned, 16 plex or 16-4 plex, Signatera does that. It's a tumor-informed test. You have emergence of non-informed tests as well, where you just send a blood test and you're going to find DNA that you are calling out tumor-based DNA. Now, as you can imagine, you can be detecting other things than kidney cancer in this case. And in fact, if you use this enough in clinic, you may come across some lymphoma cases of indolent lymphoma cases that you'll find just by doing a tumor non-informed test. That happened to me several times actually by now. So the merits of this study is to use a tumor-informed test. They had tissue, they had blood, and as you said, they're already exploring a next generation, test by not focusing on 16 only of the most informative somatic mutations, but actually going after the 64 mutations. You expect a higher sensitivity, you expect a higher ability, to detect low MRD, and less likely to find false negatives. When you look at that in the KEYNOTE-564, in the context of adjuvant pembro data, you actually see more detection rates, right? It goes from 5-ish% to over 8%, if you will. So half more positive cases compared to the 16. So that is aligned with it. The specificity, is already high, and so we remain high. But I will say, what is the caveat? The caveat is the sensitivity, even though it got better, it was unable to detect or to identify most patients who eventually relapse.
It was not good enough, probably, let's say.
Right. So it's going the right direction. I just don't think we're there yet.
And it might be also an issue with the number of events. I mean, at the end of the day, the number of recurrences is also not as high.
You're absolutely correct. I mean, if you need to have all the samples available, which is, and then you have to have the events to do the statistical analysis, right? To your point. And so you lose events, you lose the power to detect a difference, right? If you will. It's proof of concept, correlative evaluation. I think is important. I think there's learning lessons that we can take from it. And I do think we're going the right direction. I don't think we're ready yet, but I think that's how medicine evolves and science evolves.
So just to summarize and to keep it simple, for patients that actually had ctDNA positive, it was actually prognostic for those patients. And with the patients that had negative ctDNA, we didn't really know what was happening. It could not predict any response to the treatment, to pembro.
Right. So the message out there is, if you're finding a reason to do immunotherapy to a patient and you want the information to help that conversation, maybe a test like this can help you. Keep in mind, it will take you a few weeks to get the test back because you need to send tissue and blood.
How do you counsel your patients now then?
Right. So, when I see these patients in clinic, I always stage them post-surgery. and you have about 3 to 4 months to kind of get them on adjuvant therapy, right? The similar way it was done on trial. So I do find that time, but some people out there may have a different strategy, right? So I never start them the day I see them, because often they need to be restaged at that point post-surgery, which comes to see me usually 3, 4, 5 weeks after surgery anyway. So by the time I'm basically comparing with scans done 3 months prior about that. So I restage them, and that's a good thing to do as a practice, is like make sure you know the patient doesn't have evidence of disease, because that will definitely change the conversation. And the other piece of the story is, if you have these tests, you should not decide on the benefits of adjuvant pembrolizumab in the context of a positive or negative ctDNA based on the information we have from these tests. That's my opinion. And of course, we also do not know what the new approval of adjuvant pembrolizumab with belzutifan means in regards to these MRD tests, because this was done in the context of IO pembrolizumab monotherapy and not combination with belzutifan. So I think it's important, it's good to have. For some, I feel slightly not ready for prime time yet, but as long as we understand the potential benefit and ending to the conversation with the patient, it's all good. And again, as I think it is aligning, is going the right direction. We just need to be aware of the limitations of the information we have today.
So basically, we summarize that ctDNA remains a promising prognostic biomarker for renal cell, but this analysis does not support its wide use to select patients for the adjuvant treatment. And until we don't have anything better, we still base our clinical decisions on pathology. That's what we have been doing, right?
That's right. In addition to, of course, the disease characteristics, as you said, as well as the patient characteristics, right? Are you a candidate for immunotherapy? Are you a candidate for the combination with belzutifan? So other aspects are relevant, right? Autoimmune disease, immunosuppression, anemia, et cetera, that you take into consideration to make the decision. Logistics, whether or not you're going to commit yourself to a year worth of treatment, right? And what does that mean for you specifically?
Work-wise, also a lot of items, to take.
Exactly.
Sounds good. Thank you so much, Pedro, for your time. And I think we clarify what is the role of ctDNA nowadays in high-risk renal cell carcinoma.
Pleasure to be here. Thanks for having me to talk about this important topic.
Thank you for listening to this episode of EAU Podcast. To keep up to date with the kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.